now have another very interesting topic. Whenever I used to go to international conferences, मैं एक ही चीज़ attend करना चाहता था कि यार ये myopia और glaucoma में कोई फ़र्क बता दे. So I was never actually able to get a good this thing. So today I think Suneeta will clarify for us that it is a patient of myopia. Is he actually suffering from glaucoma or not?
Thank you, Dr. Harsh, for giving me this opportunity. So I'll be talking about difficulties in diagnosis and management of glaucoma in myopic eyes. So we are all aware of the association between myopia and glaucoma. While the two conditions can coexist, there is often a diagnostic challenge. And why myopic discs are more predisposed to glaucoma? Because there's stretching and thinning of the lamina cribrosa, which is the primary site of damage, which leads to decreased distance between the retrobulbar CSF space and the IOP compartment, resulting in the steeper patient gradient, pressure gradient across the lamina cribrosa, causing more predisposition to glaucomatous optic neuropathy. So these patients are more predisposed. And why it is difficult to detect glaucoma in myopic eyes? Because glaucoma is assessed clinically, as we have discussed, by optic nerve head evaluation and visual fields. And there is uneven expansion of the posterior globe wall, which leads to tilting of the disc and parapapillary changes, and thereby making the disc evaluation more challenging. Also, there are degenerative changes in the retina in myopia, which could lead to visual field defects that can mimic those seen in glaucoma. Also, progression is difficult to detect because the myopia will also progress, and with progressive tilting of disc, it leads to difficulty in detection whether the progression is because of myopia or because of glaucoma. Intraocular measurement, pressure measurement is also not accurate because of the thinning of sclera and cornea, which will alter corneal hysteresis. So the evaluation of glaucoma in myopia requires a multimodal approach. So the morphological diversity of optic nerve head in myopia includes tilting and cyclotorsion, myopic conus, parapapillary atrophy, and these discs are often very large with large discs and cups, and thereby mimicking glaucoma. Also, NRR may not be interpreted correctly because of the shallow cupping and tilted disc. So NRR may look pale. So tilted discs are very prevalent, very common in myopic eyes, almost 40 to 60, 70% as compared to the normal population. And when you see the disc like this, which is more or less like a D-shaped optic nerve, and you should be seeing these discs in a stereoscopic manner, wherein one half of the disc will look elevated and the contralateral half depressed. Torsion, which is the rotation of the sagittal axis of the optic nerve more than 15 degrees, is again very common, and sometimes you get to see these discs which are 180 degree torted. So you need to identify these morphological variability. Parapapillary chorioretinal atrophy, we know the alpha zone and beta zone. Beta zone where there is loss of RPE. So beta zone and alpha zone may be common in myopia, and beta zone is more common in glaucoma. But now with the advancement in OCT, with the spectral source OCT, we are now able to diagnose or detect the other zones, the gamma zone, which is the zone between optic nerve head margin and Brooks membrane termination. And you just see the scleral flange here, which is present. And there is no vascularization within 15 microns, and this is called the delta zone. So this is a normal disc, and this is the glaucomatous disc with the meta zone. And this is the myopic disc. As you can see, large disc with large disc with no cupping, shallow cupping, and myopic conus, and this delta zone. So you have to identify these morphological variations. As far as visual field analysis is concerned, the myopic retinopathy would lead to visual field defects which cause obscuration of the glaucomatous defect. However, one should remember that the defects due to myopia may affect area around the blind spot. So the defects will not start at the nasal step or the germs area as they would in glaucomatous case, in a typical glaucomatous case. So that is a differentiating point. And progressive visual field loss despite stable macula may indicate glaucomatous progression. So if your myopia is not progressing but these defects are progressing, then probably it could be because of glaucoma. So OCT in myopia, I think one should not do OCT and one should not depend on OCT, especially if the myopia is high. It could be fallacious, and one reason is that the volume scans which are required with most of the OCTs have a depth focus of about 2 mm, and there's increased curvature of the posterior wall and increased axial length of these highly myopic eyes, which exceeds this limit, leading to segmentation error. So you won't be able to acquire the entire image in one plane. That is the reason there are segmentation errors, and there is also no normative data base available for myopic population, so there is no age matched comparisons. So segmentation errors, I think you should be able to understand the OCT of a myopic eye and don't get carried away by these red defects here. And in myopia, there is temporal shift of the blood vessels and temporal displacement of the RNFL bundle because of the scleral elongation. So as you can see here, this will cause false thinning of the nasal RNFL and false thickening of the temporal RNFL. So if there are no myopic changes at the macula, then GCIPL or macular thickness parameters would be more accurate. So I think this is very important because most of the patients are treated on the basis of OCT nowadays. Red disease can also be caused by these temporally shifted bundles. As you can see, these bundles are shifted temporally here, causing red disease. Actually, the patient doesn't have glaucoma. So I would take you to a few cases now. So this is a patient who was myopic with high axial length, normal IOP. You can see tilted and torted discs, and OCT showing segmentation errors and a red disease. However, the visual fields are more or less normal. So I think you have to depend on visual fields in such cases. Another patient, again he was diagnosed as POAG somewhere else. He had advanced cupping and he was on PG analog, and you see the status of retina here. You can't even identify the neuroretinal rim. There's such an extensive parapapillary atrophy here involving macula, and OCT is a strict no-no. Don't ever treat your patient based on OCT. And if you carefully look at the fields, you can see this, both the changes are present. Because of the myopia, you see this enlargement of the blind spot here around the blind spot. There are scotomas and there's nasal step also. And over a period of time, this nasal step and the superior arcuate scotoma is progressing. So that is suggestive of progression of glaucoma. So you have to be very, very meticulous. This is another patient. And you see these horizontally oval discs with the crescent inferiorly in both the eyes. So again, these are the fields. So you have to correlate your clinical findings, and again I would emphasize that OCT is not useful. So clinically, IOP is not always elevated in myopic patients, as we heard about normal tension glaucoma. So look for IOP fluctuations to rule out normal tension glaucoma. CCT should be checked to identify falsely low IOP measurement. Also a history of refractive surgery. You need to elicit the history of refractive surgery because some of these patients may have undergone refractive surgeries and you may get false IOP reading. Careful evaluation of optic disc and be aware of fallacious OCT findings. Glaucoma may progress quickly due to lamina cribrosa thinning. So regular follow-up is very essential and you have to correlate everything. And one thing about OCT, if you have to perform OCT, then don't rely on color coding. Instead, compare the patient's own OCT in follow-up also. And if there's any progression, then or minus change suggestive of progression, then you can consider treating the patient. And if no myopic maculopathy is present, then you can consider doing macular OCT. Early management of these patients are very important because surgical management is difficult because of the altered scleral biomechanics when compared to normal population, and be cautious about doing glaucoma surgery. And this is the only situation when the scleral rigidity is low that you do not use mitomycin C for a long time and higher concentration, because it can lead to disastrous consequences. So judicious use of mitomycin C is warranted. So there are no hard and fast rules for diagnosis of these difficult cases. Treat each patient individually, do a careful examination taking everything into consideration, the risk factors, the optic nerve, visual field, IOP and CCT, and it is reasonable to err on the side of caution. And one thing which is very important to know is that every glaucomatous eye you need to consider as, every myopic eye should be considered as glaucomatous unless proven otherwise. So if there is slightest suspicion, please err on the side of treatment. Thank you.
Thank you very much, Suneeta. I think perfect finish. And the last slide was very, very important. Sorry, I forgot to introduce Suneeta. She is the head of Department of Glaucoma in Shroff Charitable Eye Hospital. But she's a wonderful, wonderful surgeon. And with Shushmita sitting somewhere here, she is one of the few people who have really gone into the angle and done the first trabectome, Kahok and whatnot. So very nicely explained, Suneeta. I think the last part was very, very relevant, because you are always confused. Is it myopia? Is it glaucoma? Should I treat? Should I not treat? So like she has rightly said, better err on the side of being defensive. And you can always follow up these patients. Each patient is an individual. So you will check the pressures. More important is to check the pressure, because many times, like she said, OCT ka kuch nahi pata lagega. OCT is useless. Fields, sometimes there will be so many changes here and there, you are not sure what is happening over there. So family history, what is happening to the pressure over the time, they may be the clue to what you are going to do in this case. But better, again, like we said in NTG, like we said in ocular hypertension, better treat rather than being sorry.